So let's return to the patient's question. Why are there two separate blood draws in prenatal screening? Recall our definition of screening. Screening is the systematic application of a test or inquiry to identify individuals at sufficient risk of a specific disorder to benefit from further investigation or direct preventive action among persons who have not sought medical attention on account of symptoms of that disorder. Keeping this definition in mind, let's look at Down syndrome screening, since that's the condition for which the algorithms that use multiple serum markers with or without the ultrasound measurement of nuchal translucency were designed in the first place. Here's a graph of the incidence of Down syndrome as a function of maternal age. The blue line is showing the percentage of Down syndrome cases born to mothers in a certain age group, so that at 25 the percentage is 0.1%, which is one Down syndrome birth in 1,000 infants born to mothers at age 25. As you can see, at 40 the rate is 1%, or one Down syndrome birth in 100 infants born to mothers at that age. This is because of the problem of chromosome sorting, which affects older mothers more, as we showed in Lesson 2. But this risk of 1 in 1,000 at age 25 or 1 in 100 at age 40 is for the group of women at that age, not for any particular woman. It is sort of an average. Any particular woman may be at a higher or a lower risk than her age-related risk. The use of multiple maternal serum markers in prenatal screening is an attempt to adjust that group risk to a patient-specific risk. That is, assign a risk for each individual woman based on the results from measuring her markers. So let's look at our patient's report. She had sequential screening, which is noted at the top of the report by the small arrow. In the patient background section, you see that her age risk for Down syndrome is underlined and is 1 in 900. And finally, you see she is screen positive for Down syndrome, and next to the large arrow, she has an assigned risk of 1 in 110. This risk is assigned using a mathematical algorithm that factors in all the results for the multiple markers shown next to the large arrow on this slide, and includes the nuchal translucency measurement. You see NT-MOM for nuchal translucency multiple of the median. That was done in the first trimester, and the results of the PAP-A marker, which was also measured in the first trimester, is shown. This seems pretty complicated, and is, and we're not going to explain all the nuances of multiple marker testing, but we are going to look at it a bit further so you can understand the reasons testing is designed the way it is. The whole point of multiple marker testing for Down syndrome is, as it says on the slide, to increase detection of Down syndrome while minimizing the number of women called screen positive by the test who do not carry a child with Down syndrome. This is also called the false positives. By trial and error, it's been found that testing for Down syndrome in both the first and second trimesters increases detection and decreases the number of women called screen positive who do not carry a child with Down syndrome. And this is because testing in both trimesters takes advantage of the fact that some markers can detect Down syndrome in only the first or second trimester. So what happens with the test results for Down syndrome in the first trimester? Are they of any use in the first trimester? Well, this is a yes and no answer. The pros to reporting the test in the first trimester is that it allows an early answer, but there are cons, the most significant of which is that some of the identified cases of Down syndrome would have been lost through spontaneous miscarriage, and the rates of detection are not as good as with combined tests. The testing your patient had is an attempt to create a compromise between the pros and the cons. Sequential testing has a Part 1 and a Part 2 corresponding to the blood draws, but a report is only issued after Part 1 if the NT measurement and the markers show that there is a very high risk for Down syndrome. Otherwise, reporting is held until the second blood draw, Part 2 of the testing. But we'll get back to this when we discuss the individual tests. As you can see, there are 4 methods of multiple marker screening. In order to understand how we will discuss comparing them, you need to know how tests work. This cartoon graph is showing a population of pregnant women who have had a Down syndrome marker test. It doesn't matter if it was done in the first or second trimester. The graph is sort of a bell-shaped curve, and as you move from left to right, you are seeing the number of women who have a particular level of the marker in their blood. Since this is a group of women who are not carrying a baby with Down syndrome, as the level gets high on the right end of the graph, less and less women have that level, shown by the curve dropping off. Now, superimposed on the graph in white for women who are not carrying a baby with Down syndrome is the orange graph of women who are carrying a baby with Down syndrome. This is also sort of bell-shaped, and it is shifted because these women as a group have higher levels of the Down syndrome marker. This graph shows what we mean by a cutoff for the marker. I've written the cutoff as a Down syndrome risk rather than as a lab value for the marker. On the report for your patient that you saw earlier, the marker's values and the lab correction to standardize those values between labs, called the MOM, or multiple of the median, was shown. But the risk cutoff was also shown as 1 in 200. This cutoff is arrived at by a mathematical algorithm that is a bit too complicated to explain. However, what is meant by this cutoff is easy to understand. The yellow line is drawn at the values set as the cutoff, which means all of the women with the marker values above the cutoff are called screen positive, and women with marker values less than the cutoff are called screen negative. So what does the cutoff do for us? The orange shaded area shows all of the women carrying a Down syndrome baby who are called screen positive. This is 89% of all the women with Down syndrome. My curves are cartoons, remember, but you get the idea. So at the cutoff of 1 in 200 risk, we have detected or identified 89% of the women carrying a Down syndrome baby. But as you can see on this graph, we have called some of the women positive in the white hatched area who are not carrying a baby with Down syndrome. These are the women who have been falsely called positive. And we would say that the false positive rate, or the screen positive rate for our marker, is 3%, compared to a detection rate for Down syndrome of 89%. Now, no individual marker alone performs this well, detecting 89% of the women carrying a Down syndrome baby, while only identifying 3% of the women without a Down syndrome baby. It requires multiple markers to get this performance from our screening program, and that's why we use multiple markers. Okay, check your understanding of cutoffs and how multiple marker testing is done by doing our quiz for Lesson 3A. Then go on to Lesson 3B.
After listening to each question, pause the video and select your answer. Then listen to see if you are correct. By using the age of a pregnant woman, you can give her a risk for carrying a developing baby with Down syndrome that is specific for the group of pregnant women at that age, her personal risk for carrying a developing baby with Down syndrome, neither A nor B, both A and B. The correct answer is A. Values above the 1 in 200 risk cutoff for Down syndrome are only found in women who are carrying a developing baby with Down syndrome. True or false? The correct answer is false. Values above the 1 in 200 risk cutoff for Down syndrome are never found in women who are carrying a normal baby. True or false? The correct answer is false.